Okay.
Hello and welcome to today's teaching. Teaching today is delivered by Dr. Ashley Lau, who is based at Chelsea and Westminster Hospital. And today we will be discussing general surgery conditions. Over to you.
Okay, so hi everyone. So my name is Ashley. Today we'll just be briefly going over some general surgery conditions that you'll commonly encounter as a foundation year doctor. Just given the amount of time we have, I won't be able to cover everything, but hopefully this will give you a brief glimpse of what's to be expected. And I think next week we'll have another session on some other general surgical emergencies as well. So you'll find that actually in these two sessions, there will be some overlap in terms of some of the other conditions. So as I mentioned, we'll go over some of the common general surgical conditions that are seen. Mainly, hopefully, the session will help refresh on how to recognize certain conditions and what you're expected essentially as a foundation year doctor to initiate initial investigations and management. So I usually like to teach using sort of more case-based scenarios, because this is sort of realistically what you would encounter when you're on call or when you're seeing patients. So the first case is, let's say this patient named Mrs. M, who's 56-year-old lady who's come in with a 3-day history of sort of right upper quadrant and now epigastric pain that radiates to the back. Initially, it's colicky, but now constant, associated with multiple episodes of nausea and vomiting, but she hasn't noticed any change in her bowel habits or weight loss. There's no significant past medical history of note, but she does drink about 3 to 4 times a week of wine bottles. She's a non-smoker and works as a financial advisor. So I guess the main thing is, when you're getting a brief history, you should already be thinking about what your differentials are. So there's a host of differentials based on that history. So whether it could be biliary colic because of the location of the initial pain, which the patient described as initiating from the right upper quadrant, whether it's cholecystitis now, because now it's a little bit more persistent, or cholangitis as well. Depending on what the patient's blood test results are going to be like, if they have any deranged LFTs. However, sort of your main 3 concerns that you really need to rule out when you see this patient is whether it could be acute pancreatitis, given the nature of the epigastric pain. Sometimes, very rarely, but it has happened before, it could be a AAA. And another thing that you also need to rule out is an MI. And also another thing in your differential could be actually peptic ulcer or perforated peptic ulcer as well. So now moving back to the case after we've thought of our differentials. So Mrs. M was actually extremely tender in her epigastric region, and her obs show the following. So if you can look at, she's tachycardic, she's tachypneic, but she's maintaining her SATs. And she's pyrexial. So now we're thinking, okay, perhaps this is a biliary colic, but maybe lending towards, oh, could this patient be septic? And it should already start ringing some alarm bells that this patient is unwell. So in terms of these observations, your first thing that you need to think of is, could this patient also have acute pancreatitis? So if we're thinking about acute pancreatitis, you use the Glasgow-Imrie score, which actually is a prognostic indicator in terms of how severe a patient's pancreatitis is, because a score of above 2, the patient needs to often be escalated to critical care outreach, and often you need to do the rescoring system 48 hours after their initial presentation as well. So a really useful mnemonic is pancreas, and often as well, it's really easy. You can go on to MD Calc or just download the app on your phone to quickly do the scoring for this patient. So I think, I apologize, my slides are a little bit mixed up in order, but you do the blood test for this patient and you realize Mrs. M has elevated white cells. Potassium's a bit low as well, 2.5, but the main things of concern are that the lactate's quite high. The amylase is also really high as well. It's about more than 3 times the upper limit, and she has quite significantly deranged LFTs. So all these blood test results help collate that, okay, this patient most likely has acute pancreatitis. And as we know, pancreatitis has multiple causes, but with these blood test results, it shows that maybe it might be gallstone related, and that's when you need to do a little bit more further investigations for this. So just a brief recap about acute pancreatitis. So there's that really popular mnemonic that everyone tries to memorize, which is I get smashed. So I won't go into too much detail into it, but the essential diagnostic criteria for it is that 2 of the 3 following must be met. So patient must have upper abdominal pain, and for laboratory, either serum lipase or amylase is 3 times the upper limit of normal. So most places will still use amylase because serum lipase, although it being much more specific for pancreatitis, it's quite an expensive test. And imaging as well to confirm pancreatitis, which actually isn't often used. Usually you'll find that actually the clinical and lab results are more than enough, but if the CT, MRI, ultrasound show pancreatitis, you need 2 of the 3 to diagnose the patient. So how to appropriately manage this patient. So often as even an F1 or F2, when you go see these patients, when you're on call, you're expected to help establish initial management in terms of before the patient might be reviewed by your senior, such as your registrar or your consultant. So most cases of pancreatitis initially are managed conservatively whilst you're trying to find out the exact etiology of it. So this patient needs quite aggressive IV fluid resuscitation. So it really depends on how much you give for the patient, but in a lot of the trusts, let's say in a young to middle-aged healthy patient with no other significant comorbidities, you might consider sort of 3 liters within the first 12 hours. And then afterwards, you re-examine the patient just to see what their fluid status is before you prescribe further fluids. Obviously, if the patient has a history of heart failure or if they're extremely petite, you might need to be less aggressive. So it's really important that you do an appropriate fluid balance as well before you initiate these IV fluids. These patients will need very, very strong analgesics usually as well. So giving just paracetamol is probably not enough to help with the pain. Sometimes you might see doctors sticking the patients immediately onto a PCA just because the pain is that severe as well. So pain management is also essential because if the patients aren't breathing or ventilating appropriately, they're more predisposed to getting sort of hospital complications such as pneumonia. And also, as I mentioned before, it's really important to do an appropriate fluid balance. So you need to have an appropriate fluid balance charting, and most patients will also need a catheter as well. Make sure that you prescribe an antiemetic. If these patients are vomiting profusely as well, you might need to consider an NG tube to prevent aspiration. And usually because of the vomiting, the electrolytes are quite deranged, as you could see from the from this case for Mrs. M. She was hypokalemic, so make sure you also correct the electrolytes. And the last thing as well is making sure that these patients have some form of VTE prophylaxis, just because the worst outcome is for them whilst they're being in hospital, immobilized, developing a thromboembolic event. So in terms of now, that was sort of your initial management, what you would do. Now going on to imaging. So usually for pancreatitis, as I mentioned, you don't really need imaging to give you that definitive diagnosis. However, the imaging is really useful in cases where you want to find out the exact etiology of it or to screen for any complications. So an ultrasound would be very relevant because this would help identify for any gallstones that might have caused the pancreatitis. CT abdomen actually is not performed usually on admission. However, it will have a diagnostic and management value in patients who have pancreatitis and who have not been improving despite conservative management, because they can then detect for local complications that will occur. So in this case, what it would be your definitive management. So as we saw from earlier, the blood tests showed that this patient had quite deranged LFTs. So what would be most appropriate is you would organize an ultrasound, which should show whether there's evidence of gallstone disease. Afterwards, to confirm if there's a gallstone stuck somewhere in the biliary tree, you would then have to organize an MRCP. And in the image in this PowerPoint shown, this is an example of an MRCP where contrast flows through the bile ducts. And you can see whether or not there's any areas of dilatation or constriction to show that there might be a gallstone stuck. Once you've identified that, then you can then proceed to an ERCP to help relieve the obstruction, and that should help with treating the pancreatitis as well. And ultimately, to really treat the etiology of the gallstones, this patient will eventually need a cholecystectomy. The cholecystectomy isn't usually carried out immediately. Sometimes surgeons might want to wait for everything to settle before they go into that. So now going back to our first case, so Mrs. M stays on the surgical ward for a week, and she's finally discharged home after having an ERCP to remove a stone retained in the biliary tree. However, a week later, she returns to A&E complaining of similar epigastric pain, but this time with a swinging fever. So we've sort of treated the underlying cause to the pancreatitis. So what scenario is most likely? So would it be a recurrent episode of pancreatitis, post-ERCP related pancreatitis, or acute cholangitis due to a missed stone, or pancreatic necrosis? So actually, given the information that we currently have, all the scenarios are very likely. So it's down to, our history taking and the investigations that we'll initiate for the patient. So if it's a recurrent episode of acute pancreatitis or post-ERCP related pancreatitis, we expect that the patient will still have quite an elevated serum amylase compared to their previous admission. With acute cholangitis due to a missed stone, from the blood test results, it will demonstrate that the patient will be very septic and the LFTs will continue to be uptrending despite having had an ERCP done to remove an initial stone. So sometimes that can happen, but that's why we need to sort of start from scratch, doing the history and the investigations to help, try and find the etiology of this. And another thing is whether it could be pancreatic necrosis leading to an abscess. And to confirm this is when your CT abdomen would be relevant, because usually pancreatic necrosis occurs a few days after an initial acute pancreatitis attack. So just a brief refresher of the local complications of acute pancreatitis. So within sort of a week, you should start suspecting if the patient's not getting better from their pancreatitis, whether there's necrosis going on. And sort of after a week from the necrosis, it could become a collection or a walled off abscess. In certain cases as well, if it's just a fluid collection that's not infected, it could also become a pseudocyst as well. But again, all these things will help in terms of if you get the blood tests and the CT done for this patient. So what is pancreatic necrosis? So acute pancreatitis that leads to an ischemic infarction. So you should really start suspecting this if there's no improvement for about 7 to 10 days after the onset of pancreatitis. Often you might need to also consider broad spectrum antibiotic for cover and obtain blood cultures, because if you think about it, if there's an area of necrosis, it's a very opportunistic nidus for bacteria to attach to and to cause infection. The infection is usually formally confirmed with fine needle aspiration, which then needs to be drained either by inserting a catheter or necrostomy. And eventually you'll have a definitive treatment of the necrosis with a necrosectomy, but normally this is delayed till the necrosis is fully walled off. And usually this occurs about 4 weeks in. So that was a little bit about acute pancreatitis in terms of how you would initially manage it and some of the complications that can occur. So now we're going to move on to case 2. So case 2 is a 86-year-old male who's presented with worsening left-sided lower abdominal pain over the past few days. This is associated with slight nausea and vomiting. She has occasional constipation with occasional blood mixed in the stool, however, no significant change in bowel habits or weight loss. And the past medical history is as follows. So what are your main differentials, just based on the history? So just some that is quite common that you need to be able to be thinking about is whether it could be acute diverticulitis, diverticular disease, irritable bowel syndrome, or ulcerative colitis. So what investigations then would you request for this patient? So with investigations, we always start off with things that are most simple and then moving on to the more complicated things. So you might want to request, let's say, a set of bedside investigations, which could be basic observations, and tailor it based on that. Also urine dip as well, because sometimes with abdominal pain, the initial thing that you want to rule out is whether or not the patient has a UTI or pyelonephritis. Other things as well at the bedside you could do is basic blood tests, which you've done for this patient, and it shows that the white cells are slightly elevated. CRP is also slightly elevated as well. However, lactate is within limits, and also the LFTs are also within limits as well. So after you've sort of initiated on these bedside investigations, the next thing is to think about what imaging would you like to do. So in this patient with abdominal pain, based on bloods, you might suspect that there's some form of infection going on. So one investigation that would help is doing a CT abdo-pelvis with contrast, because it could help diagnose and exclude all the other pathology that was in your differentials. So the CT shows that there's thickening of the bowel wall with fat stranding and intra-abdominal free fluid. So based on that, the patient has most likely uncomplicated acute diverticulitis. So the difference between uncomplicated and complicated diverticulitis is complicated diverticulitis describes complications secondary to diverticular disease, which we'll go over a little bit more in detail later. So when we say complicated diverticulitis, some of the complications that can occur from diverticulitis is you can get perforation leading to peritonitis. With repeated episodes of diverticulitis as well, you can also get stricture formation. And what happens is, because of the kinking in the bowel wall that you can see here, it can cause bowel obstruction, which is another surgical emergency. In sort of just uncomplicated acute diverticulitis, sometimes if it's ongoing for long enough as well, it could wall off to become an abscess, which needs to be drained if it's large. And also in long-term or repeated episodes of acute diverticulitis, you can also get fistula formation as well. So in the image with the barium enema, it shows here, this image here with the contrast flowing through. You can see that the contrast doesn't actually go through the entire colon. It only goes through halfway because there's no contrast in the rectum. So this patient might have a diverticular stricture because of the kink, but in order to fully confirm that, either you could do a CT abdo or a colonoscopy to confirm, because sometimes it's difficult to distinguish from a malignancy. So in terms of diverticulitis, diverticulitis falls under the broad sort of umbrella term of diverticular disease. So a lot of people get mixed up. I remember I initially got really mixed up as well in terms of all the different terms. So just a sort of a brief recap, diverticulosis describes the herniation in the bowel wall, but actually only 25% of them become symptomatic. Diverticular disease is mainly symptoms from diverticula. So sometimes patients might get bloating, they might get abdominal discomfort, but it sort of passes, it comes and goes and doesn't cause too sort of significant impact on their daily living. Diverticulitis is inflammation from the diverticular disease, which actually currently is quite controversial whether or not antibiotics should be given. However, in most trusts, you'll find that antibiotics will be given for patients who have diverticulitis because it can still be, there can still be an underlying bacterial infection. So how would you initially manage this patient? So again, it's thinking about holistically managing the patient, not just focusing on their diverticulitis. So it's important that you give them the appropriate analgesics, antispasmodics, but you should also use this with caution because you can't use these in patients who might have a stricture presenting with bowel obstruction, or certain antispasmodics is also contraindicated with patients who have heart disease. You should also initiate the patient on antibiotics as well. And if they have any signs that they're dehydrated or they're septic, you would need to initiate them on sepsis 6. So part of that would be fluids as well. Most patients you'll find can be sent home with oral antibiotics with uncomplicated acute diverticulitis, unless they present with sepsis or they have other significant comorbidities that may warrant hospital admission. So what would be sort of your follow-up? So actually, if patients with acute diverticulitis don't improve, so if they have fever or leukocytosis for more than 72 hours, or just essentially any worsening symptoms, they need to have an urgent review. So it's really important that you safety net these patients when they're being discharged from hospital. Advise a low residue diet. If patients have recurrent episodes of this, they might need elective surgery to resect that part of the bowel that's causing the disease. And it's important to also warn patients that sometimes recurrence of diverticulitis might happen in about 10 to 35% of patients, which actually is quite high. So it's important to let them know and for them to be aware of the signs and symptoms so that they can seek help when needed. So let's move on to the third case. So third case is Mr. M is a 68-year-old retired weightlifter who presents to his GP with a 3-week history of dragging discomfort in his right groin towards the end of the day. The discomfort is associated with a lump on standing. So based on these things in his presenting complaint, what other questions in the history would you need to ask? So with the given information, again, you should formulate your history according to your list of differentials. So your differentials, some of the main ones that immediately should pop into your head is, could this be an abdominal hernia? So you could ask about location, screen for whether or not there's any strangulation or incarceration. So whether, it's tender, whether the patient has been able to open their bowels, whether they're able to reduce the hernia themselves, and also just screen for risk factors as well that might predispose them to getting a hernia. Another thing you need to think of is whether it could actually be an enlarged lymph node. So it's important to ask about recent illness and whether or not the patient has any red flag symptoms for malignancy. And lastly, another thing you need to think about is, could this be vascular? Could it be a saphenopharynx or an aneurysm? So again, asking the patient, oh, have you noticed it being pulsatile or it being a certain color could help point towards this. And it's important as well to ask about prior abdominal surgeries, because if it's a recurrent abdominal hernia as well, this could also change your way that the hernia is managed. So after further questioning, Mr. M tells you that the lump is located in the right groin. It's not tender, disappears when lying flat when he puts pressure on it. He doesn't have any symptoms of nausea, vomiting, no change in bowel habits, and no weight loss. So these are all reassuring because you've essentially excluded most of the red flag symptoms. And he's had no prior abdominal surgeries as well. So on examination, he's comfortable at rest, and you notice sort of a 3 by 3 centimeter lump that appears on standing on the right. So most likely, just based on the history, the patient probably has some form of abdominal hernia, which is something that you'll commonly see not just in hospital settings, but also if any of you guys do a job in GP. And essentially, for any sort of abdominal hernias, usually it's a clinical diagnosis. Additional investigations aren't usually required unless you're not sure what the lump is, or you suspect that there's a serious complication secondary to the hernia, such as strangulation or bowel obstruction. So you would have to do an ultrasound to help. Usually you would order an ultrasound, which would help determine whether it's a hernia or not in general practice. But if a patient presents into A&E with, let's say, an irreducible hernia with evidence of bowel obstruction, strangulation, or incarceration, you should do a CT abdo-pelvis with contrast as well. So how to manage these sorts of patients? If the patient's stable, the hernia is reducible, they should undergo elective surgical repair, and that's when knowing whether they've had previous abdominal surgeries is quite important as well, because if it's their first presentation and it's unilateral, usually it's an open repair. However, if it's recurrent, so they've had a prior surgery, or if they have bilateral hernias, they'll need a laparoscopic repair. Occasionally, you will also come across patients who are not a surgical candidate, meaning, for example, if they have multiple comorbidities, and sometimes to manage the hernias, patients can wear a truss, which kind of looks like this. And the truss essentially applies pressure on the hernia to help reduce it back in. However, it can still strangulate, and it's uncomfortable just looking at how you have to wear it. And sometimes it can cause a lot of irritation around the skin as well. So continuing on this case, so Mr. M was seen in the general surgery outpatient clinic and listed for an elective hernia repair. However, during his wait, he developed sudden severe generalized abdominal pain with nausea and vomiting. So what is your most likely complication that has occurred? Is it irreducible or incarcerated, obstructed, or strangulated? So most likely he has a strangulated hernia because there are signs that his hernia is now irreducible. And with severe pain associated with the hernia, normally you would think the hernia is strangulating is when patients come in with pain out of proportion. Sometimes you'll also get sort of ischemic changes that occur from the hernia. And often this coexists with bowel obstruction as well. So when you see these patients, normally you also have to manage that at the same time. And the risk of this happening is about 2% per year. So just a little bit of a progression diagram of how a hernia could become strangulated is As you can see, the aperture to which the hernia herniates through the abdominal wall is quite narrow. So as more of the hernia comes out, eventually it becomes ischemic, and as well with the kink here, it can also cause obstruction. So what would you do next? So your immediate or initial management is, if you see any patient with a strangulated hernia, it's a surgical emergency, which is time dependent, because if you don't treat it, that part of the bowel will die off. So don't necessarily need any sort of imaging to essentially bring the patient to theater. But the most important thing is you need to stabilize the patient before they go to theater. So making sure they have at least aggressive IV fluid resuscitation placed in the middle by mouth. Make sure they have an NG tube in place, because most of the time they will also present with bowel obstruction. Place in a catheter, prepare them with theater with all the appropriate bloods, and prescribe VTE prophylaxis as well. And usually this will start after the surgery. And obviously the definitive treatment is with bowel resection if the bowel has become completely ischemic necrotic, but sometimes you'll find that surgeons, once they're able to reduce the hernia surgically, they'll see whether or not the bowel will revascularize before they repair the abdominal defect. So I'm not sure if we have enough time to go through this last case, but I'll sort of try my best to run through it. So Mr. A is an 85-year-old male who's come in with bleeding from his back passage. It's associated with dark red clots, associated bowel movement, but no pain, no nausea or vomiting, or any of the other red flag symptoms. However, he has reported that it's his first episode. His past medical history includes atrial fibrillation, a previous STEMI, and hypertension. So these are the medications he's currently on. And just no significant family history. He's a non-smoker and non-drinker. So PR bleed is a really common thing that's seen in also general practice and A&E. So when patients present with that, you need to immediately think of a whole host of differentials. So the most common cause of PR bleeding, actually, especially in the elderly, is due to diverticular disease. However, you also need to think about whether or not there might be colitis, whether it's ischemic. So ischemic is when patients have sudden onset abdominal pain. And the classic history is abdominal pain with a background of AF. Also, you need to be able to rule out infection and also whether or not this could be inflammatory bowel disease. Other things are also quite common, as well as hemorrhoids, but normally hemorrhoids are really hard to see unless they're all externalized, such as 3rd or 4th degree hemorrhoids. The most important thing is you need to rule out an upper GI bleed in these patients as well, and also malignancy. Anal fissure is not likely to be in the scenario because this patient didn't have any pain when they were passing or making a bowel movement. And also angiodysplasia is also very rare and also very difficult to diagnose as well. So your main things that you should be thinking about is whether this is diverticular disease, but you also need to exclude an upper GI bleed and a malignancy. So your bedside investigation, the patient's comfortable, the PR done, you didn't really see anything in terms of masses or external hemorrhoids, but there's some residual, a small amount of residual dark blood, but no mucus seen on withdrawal. So you do your bedside investigations, which show that this patient is in AF based on the ECG. The hemoglobin, the main thing you want to also look at is whether the patient's hemodynamically stable or unstable. So the hemoglobin levels isn't too, there hasn't been a huge drop. However, the patient is tachycardic, but they're holding their blood pressure. And the urea actually is within limits. So hopefully that has helped initially exclude an upper GI bleed for you. So would you be worried about this patient? So in any sort of patient who comes in with a bleed, you need to think about, as I mentioned before, hemodynamic status. So looking at this patient, actually, they would have sort of what we call class 1 of shock, just because even though most of their parameters are normal, the outstanding thing is that their heart rate is elevated. And that's usually the first thing that goes when you start losing a decent amount of blood. So what's your initial management? Not every single patient presents with a PR bleed needs admission. However, this patient will probably need admission, especially because they're over 60 years old. They're on some form of anticoagulant, and things to think about as well is whether or not there's coexisting significant comorbidities or they're hemodynamically unstable. You'll need to essentially do your bloods to ensure that, especially if there's a group and save and clotting. Consider IV fluids for him if he continues to lose blood. And the other important things to do is stool chart to monitor the frequency of the PR bleed, which will also tell you how severe it is, and stool cultures as well to rule out infection. The other really important thing is, even though the patient needs the apixaban for their AF, you'll probably need to temporarily hold this to help stop the bleed, and you'll need to investigate the cause. So most likely this patient has a diverticular bleed secondary to being on apixaban, which in most cases will spontaneously resolve. So I think we unfortunately have run out of time in terms of just going over the other sort of aspects of common general surgical conditions, but hopefully I can